Today, we're pleased to have with us Mr. Lo Yi Chan, an architect from New York who designed the renowned Connecticut inpatient hospice facility. And also we have Dr. Barry Brooks, an oncologist and physician here in Dallas, Texas, who is the president of Dallas Community Hospice, and I'm Adrian Anderson, the executive director of Dallas Community Hospice. Okay, Mr. Chan, can you tell us some things about how you incorporated the hospice philosophy into your design of the facility at UH?
Hospice philosophy is to enable patients and families to live effectively in the face of impending death. The building that we designed for Connecticut does this by supporting as much as possible the patients and the family. The support comes in a number of ways. Probably the most important is a sense of community, of patients supporting patients, of staff, of course, supporting patients, and the family supporting other families. And then there are many other details we can get into.
Okay. Dr. Brooks, how would you see our inpatient facility that we are planning for Dallas having different needs than the facility in Connecticut?
Well, the Connecticut facility was the first of its kind in the country, and obviously they had very few models to draw on and did not have an idea of the specific needs that their hospice might be serving. But in our case, having the Connecticut model and having very effective outpatient home hospice organizations already active in the community, we have a fairly clear idea of the sort of patients we think we will be serving in the Dallas facility. And in particular, since the laws have changed recently in terms of the sort of patient that can be cared for in the home hospice organizations programs, we think that a large number of our patients will be made up of people who have what in hospice language is someone without a primary caregiver. That means that someone who lives alone or someone whose family is at too great a distance to oversee their day-to-day health needs. Those people we think will make up most of our patients in our inpatient facility in Dallas.
Lo Yi, how would you see your design of an inpatient hospice facility in Dallas being different from that in Connecticut? I know that this is kind of a tentative question, and we're not sure where our location would be. But can you speak to that at this point? Do you have ideas of what the differences might be from your visit?
Adrian, there's some obvious answers. The climate, of course, is different, so the relationship between the inside and the outside would be different. Dr. Brooks has mentioned already the population will be slightly different. I think the most important thing is that we've learned a lot since in 10 years. The hospice operation in Connecticut, the outpatient operations is 10 years old now, and the inpatient operation is about 4 years old. And I think we should learn from what we did and change. Now, one of the principal things that we tried there was a 4-bedded ward. In effect, really 12 beds in one large room with some sense of separation into 4-bedded wards. That has proven effective in Connecticut, and yet there is a strong impulse towards single rooms and double rooms. And I think one of the things that Dallas should consider very carefully is whether the 4-bedded ward works best, whether for single at a 2, or what combination makes sense. I think that's a crucial issue because it determines so much else of what happens in the building.
Thanks, Terry. Barry, I know that you have been talking to the physicians and the hospital administrators and other healthcare providers and the home hospice programs in Dallas about the location of an inpatient hospice in Dallas. Would you speak to that at this time and tell us the kind of feedback that you've been getting about the people's feedback about location?
Yes, Adrian. The site location is clearly crucial in the development of an inpatient facility, especially in a large, sprawling community like Dallas. The site has to be accessible to a large number of people, and it also has to meet certain standards. That is, it has to be near what hospital administrators refer to as the central hospital district. And hospital administrators have emphasized that to me in my conversations with them, meaning that it is unlikely that doctors and nurses and social workers in Baylor or in St. Paul or Medical City Presbyterian hospitals, for example, would refer to a facility in far south or west or east Dallas, and that in fact we're targeting an area more or less centrally located, perhaps somewhere between north of downtown and south of Northwest Highway. The east and west boundaries of that are less clear, but that would be accessible to all of the major hospital facilities in Dallas. It also would be acceptable to all of the hospital administrators in the various larger hospitals. Beyond that, site location needs quite a bit of thought and will obviously have to be accepted by the community at large. And perhaps Mr. Chan can talk about some of the problems they had in Connecticut in selecting an appropriate site.
Well, one of the things we came upon was the romantic idea that somehow when you're close to death you should be on some mountaintop with some beautiful view of the ocean. And there's a lot to be said for that. But that seems to exclude so many other things that are necessary at that stage of life, primarily health givers, but also the family. Not everyone can be on that mountaintop. And so that has just the opposite effect. You want to be right in the center, right downtown, 100% corner, as the real estate people call it, where easy access by everybody. I think we tend to go toward the access much more than toward a place of great peace and isolation. Balancing the two, the access is more important. Now that raises quickly a problem of the fact that once you make that position, you're right where the action is, right where a lot of other people have reasons to be there, which raises the cost, right where neighborhoods have already been established, which means you are a newcomer to the neighborhood, causes those kind of problems. These are things that factors that Dallas will have to address as it looks for the site.
Do you feel that in working with us to do a design for an inpatient hospice, that being located in the central hospital district, essentially where there's a lot of freeway traffic and noise and activity, that is going to change your design markedly from the facility you designed in Connecticut?
Freeway traffic noise sounds bad at first hearing. I'm not so sure it's a totally negative thing for a hospice. Again, it goes back to the point I just made about isolation versus activity. When you balance the two, you need activity. Now, is freeway noise a welcome activity? That's something you have to think about more. Obviously, in many cities, including Dallas, have the problem of noise, and you can shut the windows. And often with the climate here in the summertime, the windows will be shut anyway. But there are also times when you want some noise. You want a sense of life, even if it's nothing more than the blur of traffic. So that's a very interesting consideration for this design.
So basically, you're saying that you think you can turn some things that might be negatives into positives by incorporating into your design provisions for that.
Mm-hmm. Yeah, I would define the negatives as not necessarily negative.
That's great. Well, the other thing I think it'll be interesting to talk about is the things you told us about how you've done transitions in the hospice. Like, you don't need to be filming this. Like how you enter it so that you drive around and then how you come into the patient rooms. I thought that was very interesting. Do you think that's something that people are...
Yes. Okay, the idea of transitions it's not hard to understand. I recall visiting a friend who had just had an emergency operation, and she was still in intensive care ward. And I was told to take elevator to the 5th floor, and I came to the 5th floor, and when I got out of the elevator, there was a door in front of me, a glass panel in it. I could see through that glass panel all kinds of machines and people bustling about. I just couldn't force myself to just open that door. finally somebody opened the door going the other way, and then I walked in. And right there was my friend, with all kinds of drips and tubes, and it was just a very difficult situation for me as a visitor. I didn't know what to expect, and I had to confront it all at once. The idea of transitions in the building is that you make that a set of progressions so that you slowly confront what you don't know, what you're unaware of what's going to happen. You're told that your aunt is very ill, may not live. You don't know what you're going to expect when you come there. Now, that's done by having anterooms, foyers, the ability to see some distance so that you don't go through a door and just it's right there. It starts even as you enter the site, as you drive your car into the site. Instead of just driving to a parking lot and walking up to the door and going in, you could drive actually around the building, all the way around perhaps, and see through the glass windows what's happening inside, get a sense that what's happening inside is really part of life. It's not some mysterious thing back there. And see children running around. And then when you come in, you're met, and there's a human presence. There's a coffee pot perhaps, so that if you don't want to go right away to the patient's room, you can stop. Maybe even a gift shop, you can pick up some flowers or something like that. Ways to slow down the progression of entrance. Now, this sounds expensive because it deals with lots of extra space, you would think. But the key to it would be to use that space that you create for transitions, at least double it or triple it, so that the transition spaces are not just ways for you to slowly confront what's going to happen, but for other people to have access to closets and linen rooms and so forth like that, so that the space is used twice, at least twice. So then you can justify it economically. But I don't think there's any doubt that you can justify it psychologically. It's the right thing to do.
Okay. Do you feel that you were heavily influenced by your visit to St. Christopher and your interaction with Elizabeth Kubler-Ross and Cecily Saunders?
Oh yes, Dr. Saunders and Elizabeth Kubler-Ross were the key people in everybody's thinking back in the late 60s. They had done so much groundwork that when the hospice movement started here, which was like the early 60s, they were the people everyone looked forward to. It was natural, therefore, that I went to England to look at the only two hospices in operation in the world at that time. It was Dr. Saunders, St. Christopher's in New London, and St. Luke's up in Sheffield. And what I saw there were some mistakes, some really good thinking, a somewhat different culture from ours, in fact, a much different culture in the sense that it's a monolithic society, so everyone really supports each other. Not such a huge ethnic differences as we have in the United States, but still basically human beings have a lot to learn from what happened there, and still a lot to learn from what's happening there. They're still somewhat ahead of us, particularly in terms of education. It's a public health service there has a system where the nurses come into the hospice and actually work with the hospice patients and then take their knowledge back into the countryside, other parts of England, and spread the hospice philosophy out.
So education and research are an integral component of St. Christopher's?
Very much so.
From the beginning? From the
beginning, because they were the first. And they knew they would get people like me coming over there. As a matter of fact, when I was there in the late 70s, they were averaging 100 professional visitors a day. That's a lot of people. And they built separate buildings just to accommodate that influx of interest. It's a sort of thing that will happen here too, as hospices are built here.
How long have you been involved in the hospice movement?
I started in 1972, so that's 12 years. I've been thinking about this for a long time.
Well, you certainly have. You're certainly articulate on the subject. I can't. Can you think something else you want to say? Where you want me to speak?
Not that we don't have them involved, we do.
Yeah, very involved. But I wonder how we can. The clergy have been very instrumental in our development to this point. How would you see their continuing to interact and facilitate our move to select a site and to actually start constructing a facility? What do you see their role in this stage of our development?
Well, Adrian, as you know, they've been instrumental in most of our fundraising activities to this point. In addition to that, in the coming days, when we get down to the nuts and bolts of site selection, the clergy are going to be absolutely essential in community acceptance and community education about what hospice represents. It is still a fairly foreign concept to most lay people, and perhaps a threatening one. And we see the role of the clergy as being absolutely critical in our more or less community education projects. The clergy in general, since they are involved on a daily basis with the counseling of dying patients and the families of such patients, understand more clearly perhaps than the members of their various churches the need for such an organization as inpatient hospice facility, where all the various technologies and advances that Mr. Chan has spoken to can be focused and where people can be cared for better than perhaps they have been in the past as they near death.
That was real good. Volunteers are an integral part of the hospice concept in the delivery of care, but in the planning stages, how did you use volunteers when you were putting the Connecticut hospice together?
We underestimated the part of the volunteers. We always knew there were many, and we always knew they had to be very thoroughly organized so that there would be lockers and all that sort of thing, and this volunteer director channeling things. We just didn't anticipate the tremendous variety of kinds of things that our volunteers can do, and their crucial role in the hospice. And so we didn't provide enough space for volunteers in New Haven, in Brantford. I think it's very important to recognize that mistake and correct it if Dallas is anything like Connecticut. Let me give you an example. We have, on the one hand, for volunteers, a volunteer coordinator. So that person is administrator, runs things just like any administrator, needs desks, filing space, and so forth. That's easily understood. And on the other side are the people themselves. Now you can understand, let's say the garden club, they'll come in and keep the site absolutely beautiful, flowers all over the rooms. That's easy to understand. But how about someone who's a piano player? How can you use a piano player? What we did was we had a piano, obviously, and it was in the center of the building. And when the piano player came and played, the sound drifted all over that building, and people who were paralyzed and couldn't move, and therefore couldn't get to the sound, could hear it, and it was delightful for them. Now, if we had not provided a place for the piano, we would have missed that. That's very important to understand, that these kinds of things that you don't anticipate will happen. People bring things to the hospice. You don't anticipate them right away, but they happen, and I can remember another one. This was in England, where in the peace and quiet of the hospice in St. Christopher's, suddenly heard bagpipe. You know how loud a bagpipe is? Well, there's this guy in a kilt with a bagpipe walking up and down the wards with the loudest sound I ever heard, the last thing you'd ever expect in a place where people were dying. Right? Patients were delighted. It lasted maybe 30 seconds, and then the bagpiper was gone to the next ward. But that's a thing that the volunteers can do. Maybe I stress too much the music, but that's one of the things that seems to permeate the hospice. There's, of course, art, a lot of crafts. That's more one-to-one, working, keeping people's hands working so that they still feel capable of doing things. Then, of course, the more mundane things like just being able to move beds around and serve tea, let's say, on the terrace. Lots of things volunteers can do.
What about things volunteers do that don't have to do with direct patient care? Do you have a lot of that in Connecticut?
Yes. There's quite a bit of work that the volunteers can do just in terms of fundraising and education, speaking to Jews groups, for instance, and bringing children's groups in to see what the hospice is like. Lots of that. It's probably more so in this kind of facility than in a regular hospital, in a standard hospital. And another thing to remember here is that that survivors become volunteers, and they are the most valuable volunteers because they have gone through the experience. It's not that you would ask them to sort of counsel other patients or counsel other family members. It's just their added understanding of having gone through an experience makes them a better gardener. I can't explain it.
I think that certainly you made reference to the fact that if Dallas is like Connecticut, there will be a lot of volunteers. Certainly it's public-spirited and sort of volunteer-oriented as the Dallas community is. I think that they will play a crucial role in the development of our hospice and the everyday running of it. And furthermore, with our somewhat greater distances, the American Cancer Society has a very extensive network of volunteer who serve the role of transporting patients and families to and from various facilities. And I think that we will be able to enlist them to bring families who are perhaps unable to travel within the city to the facility and then back again. And I could even foresee that could be a fairly sophisticated network. I've already written that down.
Put his name on that board and see, he's one of the people that has sponsored the
The only problem is
you won't have time to come to meetings.
the National Advisory Committee. I understand the pros and cons.
What do you foresee that we need to do in the near future so that you can move ahead on your design of an inpatient hospice facility for Dallas?
It seems to me the first step, we've done a lot of work already, but the first step we need to take now is to pick a site. Now, in Connecticut, we had great difficulty picking a site because it's a very highly developed corridor that we were looking in. And it proved very important to us that we have the support of the local governments as we went from town to town looking. And finally, when we did pick a site in Brantford, it was the key to that choice was that the town of Brantford, the local officials were totally behind our efforts, as well as the state of Connecticut. I would expect something like that would be true here of Dallas, and therefore I would think that you would be, while you're looking for a site here, you would be talking also to not just real estate people, people who own the land, but also government officials here in Dallas. Would you agree to that, Barry?
Well, certainly. I think that the support of the city and county will be very important in our ultimate site selection.
Site criteria, we've already mentioned earlier about wanting to be in the center of things and wanting enough land so that you can accommodate some outdoor uses, plenty of parking, because one of the things that hospice will have are a lot of visitors. And the hospice you're developing will also have a lot of professional visitors, so you need a fair amount of space, easy accessibility, and of course, proper exposure, as many trees as you can find, the kinds of spaces you want for any good development.
Line on track here. But you have helped us more than you know in terms of focusing our priorities and sort of things we need to be doing.
Gave us some price differences, and we just kind of estimated these prices at for
In New York, I just want to make sure that when you shift those numbers to here, we don't ourselves shift it.
you know, hospital building costs and things like that in Dallas. I mean, he was saying he could.
This is for hospital costs.
Okay.
Nursing homes and hospitals.
All right, I'll ask him that and send that to you so that I mean, I'll keep a copy thing that he could.
Connecticut had such a thing, and we will send you a letter contract. And I would suggest working on a time basis.
Mm-hmm. What?
It should not be a time basis later on because it's very hard to control it.
what your time is too, I
No,
would think.
We keep accurate of our time. We always do that anyway.
Need quite a